And then the following day, what they'll do is do sometimes what's called a multiple sleep latency test. And in this study, what they do is they put you in a quiet room, let you hang out there for a while, and then they'll say, okay, get into bed, we're going to turn the lights off, see how long it takes you to fall asleep. And again, I said the average person takes them, maybe 5, 10, 15 minutes to fall asleep. So they do this, and they have you take these naps 3, 4, 5 times that day. So the sleep specialist calls me up a couple weeks later after he read the sleep study. He's like, Chris, I just read your sleep study. Are you still working? I said, well, yeah, I work a lot, as a matter of fact. He's like, most people with sleep apnea, this matter on disability. I'm like, you're kidding. I said, I feel okay. He's like, oh, it's because you're young and you have energy. He said, but we really need to get you on CPAP, because sleep apnea isn't just bad because it makes you tired the next day. Sleep apnea is bad because it tremendously increases your risk of really bad things happening to you medically. Heart attacks, stroke, high blood pressure, developing a condition called primary pulmonary hypertension, which basically means because of poorly oxygenating your blood at night, the tissue in your lung changes and becomes a little tougher to push blood through. So it becomes so hard to get blood pushed through your lungs and be oxygenated that you can develop a specific type of heart failure. And about the only way to fix this is a lung transplant, which we do now, but you really don't want to be involved with that if you can avoid it. So I said, okay, I'm asymptomatic, but I don't want to have an early stroke, heart attack, or buy myself a new pair of lungs for my 50th birthday. So great, I'll go on CPAP. And he said, but about your sleepiness? He goes, you don't feel sleepy? No. He said, how long do you think it took you to fall asleep on your multiple sleep latency test? Oh, I don't know, 5, 10, 15 minutes? 3 minutes. My point is, people are sometimes really poor judges of how they sleep and the quality or quantity of their sleep. So one of the best things you can do, ask your bed partner. Ask their spouse about their sleep patterns, and sometimes you get a very different story. So what do we do when somebody comes in and we're sort of evaluating their sleep? What are some of our recommendations? Well, our first recommendations are for good sleep hygiene. Sleep hygiene refers to non-medication things that you can do to help improve the quality and quantity of your sleep. And there's a lot of great recommendations. Number one, going to bed and waking up the same time each day. Even on the weekends? Even on the weekends, technically. If you can get yourself more into a pattern, a regular daily routine of this is the time that I go to bed, this is the time that I wake up, that helps. Sleep begets sleep. What else? Just paying attention to your sleep environment. We're a pretty connected and wired world these days. So you try to dissuade people from having big screen TVs and Xboxes and stereos and computers in their bedroom. The bedroom should be for sleep and sex. That's about it. So your body just sort of behaviorally knows that when I'm here, that's what I'm here for. Having a room that's just sort of physically comfortable, having a room that's quiet, dark, cool. People tend to sleep better in a little cooler temperatures in general. Other things that you can do to pay attention to sleep hygiene, what you avoid ingesting late in the day. Nicotine, caffeine. Caffeine is a really common part of all of our lives. And it's funny because if you look at caffeine, if you look at the studies that have been done on caffeine, if it never existed before and somebody all of a sudden developed this new product called caffeine and brought it to the market, it would be a controlled substance. By the rules of the FDA, most likely, if caffeine were brought to the market today, it would be referred to as what's called a Schedule 4 controlled substance. That means it would be lumped into the same category as things like Xanax or Valium or Klonopin or Ambien or Lunesta, because it's that much of a reinforcing effect, and it's not a physiologically inert substance. That means it does affect your body. It can increase your blood pressure, your pulse rate, and really be disturbing to your sleep. Well, doc, it's okay because I stopped drinking coffee after dinner. How long does caffeine stick around in your system? It takes about 20 to 24 hours to clear 95 to 99% of caffeine out of your body once you've had it. So we usually tell people if they're having trouble with sleep and if they do use a fair amount of caffeine, that's one of the first things we recommend they take a look at. We try to decaffeinate people, or at least try to have no caffeine after noon. What else? Nicotine. Nicotine is sort of a misunderstood substance because it's both a stimulant, a wake you up kind of substance, and a depressant, a relax you substance at the same time. So people sometimes that smoke say, well, I should have a smoke before I go to bed, it helps relax me. Well, it may feel like it's relaxing you, but physiologically what it's doing to your body is it's a stimulant. And it can hurt your sleep. What other kind of things do people resort to help with their sleep? Alcohol is probably the most common thing, right? Nightcap makes sense. A little glass of wine, a little cocktail late in the evening, relaxes me, helps me fall asleep. That is and isn't true. Alcohol turns out to be a pretty good way to knock yourself out. The problem is your body starts to metabolize alcohol within a couple of hours of having it, and you get into a little bit of a withdrawal state. And alcohol gets turned into different chemicals by your liver, some of which can be pretty disruptive to sleep architecture, meaning that it prevents you from getting into as deep of a sleep as you should, and it doesn't allow you to progress through the normal different stages of sleep. So alcohol will help knock you out, but you pay a price in that it worsens your sleep once you're already asleep. Other things that people use to help treat their sleep, over-the-counter medicines. Benadryl. Benadryl is an antihistamine medicine that people use for over-the-counter for allergies. And a lot of people will use it as a medicine to help with sleep or help them relax because it is a sedating substance. Benadryl turns out not to be a great long-term sleep medicine because you build up an immunity to it over time. And also because it tends to leave people feel a little bit fuzzy-headed the next day. And that's the problem with a lot of medicines that we use for sleep, whether they're prescribed medicines or over-the-counter medicines. Other things that people have used things like natural supplements like kava, valerian root, chamomile tea. All of these things have sort of mini Xanax-like effects. They can be helpful to some people, but that entire class of chemicals is very similar to the older class of sleep medicines. Now, our older class of sleep medicines are a class of medicines called benzodiazepines, and these are medicines that include the members of this family being such things as Xanax, Valium, Klonopin, Ativan, Librium. These are all anti-anxiety medicines that will help you fall asleep, but very similar to alcohol, they tend to be disruptive to your ability to stay asleep. So a lot of times people will go on these medicines, like one of the older class of those medicines, and find that initially, for the first week or so, it does help them fall asleep, but after that they build up a tolerance to it, and it doesn't help them sleep so much anymore. And people that are maintained on them chronically find that, I'm falling asleep okay, but gosh, I'm still tired when I wake up in the morning. And it's because they've traded quality of sleep for quantity of sleep. So they may be sleeping more, but the sleep they're getting is not very efficient, and they're not getting to the deeper, more restorative stages of sleep. About 10 years ago, we saw the advent of a newer class of sleep medicines called the non-benzohypnotics. These are cousins of the old sleep medicines, but they're cleaned up versions. And these medicines were an advantage because they didn't do the bad things to our sleep architecture, to our ability to maintain sleep and to sleep well in the lower stages of sleep, like the old cousins did. So these medicines were preferable because they worked well at getting you asleep, and they did a better job of keeping you asleep, and you didn't tend to develop tolerance to them. They were a little bit less addicting or habit-forming, and they did not mess up the normal progression through the different stages of sleep. So they were a big advantage. But not without their own problems. These medicines, even though you're much less likely to build up tolerance to them, some people appear to do that. Even though they have a lower potential to become addicted to them, it's not impossible to become addicted to them. One of the complaints of some of these classes of medicines have been that they don't keep people asleep long enough. So a lot of people felt like they were getting more of a benefit falling asleep, but less of a benefit in terms of staying asleep through the course of the night.